Very good morning, everyone. Our greetings from Indian Society of Gastroenterology. We are conducting ISU master classes. That's a series 2. And in this series 2, we are discussing the clinical case discussion with residents from around the country. In this series, we have residents coming forward to present a case from different part of our country. And we have a galaxy of faculty member from, again, different part of our country participating and teaching them on how to approach a particular clinical scenario and how to plan treatment and how to investigate these patients. So this have been, till now we have done 5 master classes and all have been quite good. We received a very good feedback from residents that, and not only residents, but many of the ISC members, senior people, that this is going well. We also request you that please do send feedback to us that how do we improve the quality of these master classes, especially in terms of contents. If you don't like contents or you want something to be added in the contents, then please let us know. So today we have one very important clinical case, that is hepatocellular carcinoma in a patient with a chronic liver disease. We know, all of us know, this is a very, very common clinical scenario. And to discuss this specific clinical case, we have a team from Mumbai, the KEM Hospital in Mumbai, from where the case will be presented. And for that, we have 3 renowned, I would say, teachers and teachers of teachers as a faculty today, starting from Dr. Shiv Kumar Sarin, and he's one of the best known hepatologists in the world. Dr. Sarin is at Institute of Biliary and Liver and Biliary Sciences. We have Dr. Anil Arora. He's a professor and head of gastroenterology at Sir Gangaram Hospital in Delhi. And Dr. Akash Shukla, he's also head of gastroenterology at KM Hospital. All 3 very well-known esteemed teachers. So looking forward to hear from them. You can use chat box is available. Put your questions, and all of them will be happy to take your questions through Siddharth and Ankita. I also need to introduce Dr. Aditya Kale. Dr. Aditya Kale is assistant professor of gastroenterology at KM Hospital, and he will help us in conducting this session. With this, welcome you again, and I hand over to Dr. Arora, Dr. Akash, and Dr. Sarin to take the proceedings forward. Dr. Arora, want to start, sir?
Yeah, Doctor, yes. Dr. Sarin, you want to start, sir? You can.
No, I said start, Siddharth.
Akash, you need to introduce.
Yeah. To introduce the 2 presenters today, Dr. Siddharth Harindranath and Dr. Ankita Singh. They're both 3rd year DM gastroenterology residents from St. GS Medical College, KEM Hospital, Mumbai. And we have as a facilitator, Dr. Aditya Kale, who is a brilliant young gastroenterologist at St. GS Medical College and KEM Hospital, Mumbai. He has done his DM training from Tata Memorial. So he is the most appropriate person to discuss, to facilitate today's case. So over to you, Siddharth, now.
Good morning, Sarin sir, Dr. Anil sir, Akash sir. I would like to start the case discussion for today.
Move forward. Yeah.
Yeah, you can start.
So our patient for today is Mr. So next slide, please. Yeah. Patient Mr. MT, he's a 62-year-old gentleman. He's a retired clerk at BMC by profession, hailing from Mumbai. presented to us with the complaints of abdominal distension since 6 weeks, followed by pedal edema since 5 weeks. Patient was apparently all right till 6 weeks back when he developed complaints of abdominal distension, which was generalized, associated with flankfulness, was insidious in onset and gradually progressing, followed a week later by pedal edema. He reports that these complaints were associated with decreased urine output. However, there was no complaints of associated abdominal pain or fever, nor was it associated with any complaints of dyspnea on exertion or facial puffiness. There was no antecedent history of cough, expectoration, or wheezing. There was no history suggestive of any orthopnea or paroxysmal nocturnal dyspnea. There was no history of any jaundice, altered sensorium, history suggestive of any GI bleed, EC bruisability, constipation, diarrhea, or abdominal lump. Patient denies any history of alcohol consumption, injectable drug use, any tattooing, or blood transfusions in the past. He also denies any history of intake of any complementary or active medication. Patient is a diagnosed hypertensive since the year 2012.
Can we stop you here?
Yes, sir.
Based on this history, tell me the source for the abdominal distension. You have several important points in history. How can you say it is heart, kidney, or liver?
Yes, sir. So we have a patient, a 62-year-old male with a symptom sequence of initially abdominal distension followed by pedal edema. That will be an initial clue towards pointing out that the abdominal distension is of liver origin. Whereas if a patient was of cardiac...
What is necessary for saying it is liver?
Sir, the associated complaints of pedal edema as well as decreased urine output.
Yes, so where is the urine output? Where is the history of a decrease in urine output?
Yes, sir. I had in the history of presentation.
I missed it.
Yes, sir.
All right. So this started when? Decrease in urine output. Before or after distension?
So this was after the, preceding the abdominal distension. He noticed a decreased urine output. And then abdominal distension happened and followed a week later by pedal edema.
What else? You said insidious in onset. How do you define insidious?
So, insidious in onset would be, sir, he initially did not pay attention to the abdominal distension, and when then crossed a certain threshold, then he reported that now the abdominal distension has become generalized.
Conventionally, development of ascites is graded as acute, subacute, or insidious. How do you say it is acute onset ascites, subacute, or insidious? General teaching, not by books.
Sir, acute would be symptom onset within 2 weeks.
Within days. Within days. When you go beyond a week, it is not acute. Within days.
Okay.
Then subacute in weeks.
In weeks.
And when you go beyond weeks, like in months, it's insidious. All right. So when you say insidious, did you mean that from the time it started to the time it peaked, it was more than 4 weeks?
Yes, sir.
So we always ask the patient, when was the maximum distension the patient noticed? And the time it took. All right.
Yes.
And generally, the reduction in the urine is preceding, if you are very careful, or at least patient will notice the two together. By the time he notices distension, he must be having less urine. Just have to ask him carefully.
Yes, sir.
All right, continue, please. Unless
What is the connotation of this? Do you understand what Dr. Sareen is saying? What does acute, subacute, and chronic mean in terms of pathophysiology?
Sir,
Would they mean different things? Why do you want to classify? Why do you want to ask all details?
Sir, the etiology would be different when you consider the symptom onset. If it is acute ascites, then we'll be more of thinking of syndrome like Budd-Chiari syndrome, where there is acute obstruction of the hepatic vein and that results in abdominal distension. Whereas in case of subacute or even maybe a subacute presentation, it would be more of portal hypertension, or maybe in case of chronic and fast refilling of ascites, it would be peritoneal causes of ascites.
Yeah, I think what Dr. Sareen would have meant is that acute means there has to be a clear-cut mechanical obstructive component, be it the outflow tract or the inflow tract of the liver, either portal vein or outflow tract obstruction. Subacute means you have a precipitating event like continuing alcohol ingestion or maybe superimposed viral infection. Whereas a insidious onset related to liver means gradual dysfunction of the liver. So the very important aspect of history in detail will give you clue to the etiology, which will be so relevant once you are presented. You can go on.
Dr. Jayanti has asked a question. Why was constipation, diarrhea, and abdominal lump history asked?
So abdominal lump I asked because it is also one of the DD of painless progressive abdominal distension, and also constipation and diarrhea I asked specifically in this case to rule out any associated history of any spontaneous bacterial peritonitis that can present with diarrhea. On constipation, I asked as any precipitating event for an event like hepatic encephalopathy.
Continue.
Patient is a diagnosed hypertensive since the year 2012. He's on tablet, telmisartan 20 mg OD for that. He reports a history of acute coronary syndrome in 2012, for which he was evaluated, but the details of which are not available to us. But he reports that he was on tablet aspirin 75 mg since then. He denies any history of addictions. He reports that his sleep cycle is normal and his appetite and bowel habits are also normal. He's a vegetarian by diet with a pre-morbid calorie intake of 2,250 kilocal per day and 35 gram of protein. But since the last 1 month, he says that the intake is 1,250 kilocal per day and 25 gram of protein. He was evaluated for the above complaints by a local physician, where an ultrasound of abdomen was done, where he was diagnosed with liver disease with ascites, for which he was prescribed a salt-restricted diet and diuretics, following which he reports that there was partial improvement in his symptoms, and subsequently he was referred to our center. After admission at our center, he has undergone certain...
what about the family history? I might have missed something.
Sir, he does not... Yes, sir.
What did you ask in family history?
Sir, I asked if there was any concurrent history of liver disease in the family or any history of liver HCC in the family.
HCC तो पता ही नहीं यार हमें अभी कहाँ पहुँच गए थे.
Sir, liver, I asked about...
No, sorry, can you switch off this question thing?
Can we delete
what is the family history in a patient who has come to you as suspected cirrhosis?
Sir, if there was any first degree or second degree relative with history of jaundice or ascites.
What else? What else? How will you say before you have gone to etiology, what family history will lead you to the diagnosis?
If there was any
history of cirrhosis, you have asked. Family history of jaundice, you have asked. What else immediately will help you? Gallstones. If there is any family history of gallbladder stones or CVA or any metabolic trait. So this is the definition of MAFLD, metabolic associated fatty liver disease. MAFLD includes 7 conditions which must be asked in the family history. So family history of diabetes, obesity, stroke, CKD, blah, blah, gallstones, this PCOD, all those are asked in the family history. If the mother had PCOD, father had this, immediately you will say this is possible. And even Parkinson's. So anyway, what is important in a liver disease, don't think he is the first index case.
Yes.
Do not think that your patient is the index case. Most of them have a heritage. What are the familial cirrhosis for which history should be asked? You know them. Let Ankita say, why are you quiet, lady? Tell us. Familial cirrhosis. There are metabolic, you know them. I'm giving you a lead. I always help the students come out with their best.
Not in this patient, but in a younger patient, if there was
A
a
younger patient.
if there was a consanguineous marriage history.
Wilson's disease.
Autoimmune hepatitis.
Yes. Any other familial? All right, go ahead.
Does
But do
NASH run
not
in families? Can NASH run in families? NASH cirrhosis?
Yes.
Yes.
all right.
So this
Aditya, you are not audible.
gentleman presenting with decomposition. Hello, can you hear me? Hello.
Yeah, you are audible now.
First poll question. 63-year-old non-alcoholic gentleman presenting with decompensated liver cirrhosis and ascites. What would be the possible etiology in this patient? Option 1, AB, more FC.
Aditya, there's no
Option
need to read.
2, FC.
Aditya, there's no need to read these options. They're all visible.
Okay.
भाई जल्दी जल्दी पोल करो जिससे आगे काम चले. All the fellows, residents, poll instant. Okay. The majority favors NASH. Let's move.
So majority have favored NASH over Hep C over Hep B.
Let's move.
So, okay.
You have to move quickly because we have a lot in this case. Continue.
Can we have the screen share, please? So again, I think while the screen is shared, I think this answer would have varied with time. Today, I think I would agree that NASH probably will be the #1 cause, followed by Hep C and followed by Hep B. Maybe 5 years ago, this would have been Hep C first, followed by NASH and then Hep B. And maybe 20 years ago, Dr. Sareen sir will tell us whether Hep B would have been first over Hep C.
Very well taken, Akash. This is the way it was Hep B, then C, and now it is NASH. And maybe tomorrow I'll call. Okay.
So coming to our diagnosis for this patient, our syndromic diagnosis would be decompensated cirrhosis of liver. The decompensation.
Sorry, that is not a syndromic diagnosis. That's a etiology of a complication of an etiology or a disease. What is your syndrome? Ascites?
Ascites and pedal edema associated
How
with
do you summarize this patient before you give a diagnosis? Give me a one-line summary. Here is a 63-year-old male presenting with ascites of insidious onset of last 6 months, which is painless with reduced urine output. And what else?
And no other ascites, decreased output, and no other complications of liver cell dysfunction like hepatic encephalopathy or GI bleed. And the etiology of the liver disease being #1, HCV cirrhosis.
Oh no, your syndrome, the summary of the case is one line. You are not allowed 2 lines. That's a summary based on which you give a syndromic diagnosis. So let us be clear, a 63-year-old man presented with insidious onset of abdominal distension preceded by oliguria, followed by distension and fetal edema, and no history of complications of liver disease, and was diuretic responsive or non-responsive. If it was, that closes. And my possibilities are, what are your possibilities? The syndrome is portal hypertension. Syndrome is not chronic liver disease. So the syndrome is ascites, and the syndrome has a broader term as portal hypertension. Okay, you agree with that or disagree?
Yes, sir.
All right. So in that syndrome of portal hypertension, what are your possibilities? So I would put portal hypertension first and liver cell functions or dysfunctions later.
Yes, sir.
Why did I say portal hypertension is the syndrome? What is a syndrome?
Syndrome is the constellation of features that the patient presents to us with. Which
Yes,
can be
it's clinical signs and symptoms.
Yes, sir.
So your clinical sign and symptom is ascites, fetal edema.
Yes, sir.
You agree? All right. So etiology, and what is decompensation, by the way, in this?
So decompensation would be any patient with cirrhosis presenting with either ascites, jaundice, variceal hemorrhage, or hepatic encephalopathy. That would be termed as decompensation.
So 2021, the decompensation has been redefined just very recently, 2 weeks or 4 weeks ago. You can read that. I think it's a gut paper or so. And they have removed jaundice from the word decompensation. But you can read it up and update all of us on that. But conventionally, what are the 4 things in the decompensation?
Ascites, variceal bleeding, hepatic encephalopathy,
And jaundice.
jaundice.
Perfectly all right. So your patient has decompensation.
Yes, sir.
All right. First presentation as decompensation in a cirrhosis is how common? A cirrhotic presenting first time as decompensation.
Sir, it will vary with the etiology of the liver disease.
Yeah. Ankita, am I right? Ankita?
Yes, sir.
Yeah. How common that a cirrhotic presents first time as decompensation?
It's around 30 to 50%.
Yeah. You have to read the region, the etiology. It may vary. What proportion of people at the age of 70 have asymptomatic cirrhosis? %30%, 1 in 3 above the age of 70, if you do the autopsy series, these are not today's, these are of 40s and 50s, would have cirrhosis. All right. So presentation at 63 with decompensation, you have to find out in the NASH scenario, this would be less than 10% of the total population. But they're coming to you in a hospital, that's a different scenario. Let's move forward.
So the right answer, to put it into perspective, is that in a patient who has come to the hospital, the proportion of patient with decompensation is much higher than what is there in the community. So most of the asymptomatic ones will not be currently getting diagnosed. So that's what sir means to say.
Yeah. Please continue.
Moving on to general examination. Patient is conscious, oriented to time, place, and person, lying comfortably in supine position, in IV line in C2. Temperature is 98.4 Fahrenheit. Pulse rate is 96 per minute regular. Blood pressure is 110 by 66 millimeter of mercury in right arm supine position. Saturation on room air is 99%. Respiratory rate is 18 per minute. Jugular venous pressure is normal. There is no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Grade 2 pitting pedal edema is present. There is reduced axillary and facial hair noted, and no other peripheral stigmata of chronic liver disease was seen.
Why has he got an IV line?
So because he underwent certain investigations post.
All right. You are happy with a heart rate of 96 in a cirrhotic? He was earlier hypertensive.
Yes, so he's on telmisartan.
And you are happy with a BP of 110 in a hypertensive cirrhotic? Jaan nikal jayegi. A hypertensive cirrhotic is a different breed. And he has a BP of 110 by 66 with a pulse of 96. His heart is extra efforts. Just to make you understand, a hypertensive cirrhotic is a different breed of patients. You agree with me?
Yes, sir.
So what should be the renal head in a patient of hypertensive cirrhosis? Renal head means the renal pressure required to maintain the urine output. A MAP of 65 is okay for normal person. For a cirrhotic, MAP of 70 is required. For a hypertensive cirrhotic, what is the renal head required? All right, if you don't know, it should be 80 and above. Okay? And therefore, this worries me the moment I see this cirrhotic coming to the emergency or ward or whatever. And he's pretty close to SIRS. 96 से ऊपर गया तो थोड़ा 1 पैरामीटर पॉजिटिव हो सकता है. All right.
So
the next
I'll just ask one question here. Why do some decompensated cirrhotics have a higher blood pressure than others?
Because there is sympathetic overactivity.
Yeah. Sir, there's one question from the audience that they would want to know. So, Siddharth and Ankita, you can answer this. How will you differentiate whether the ascites is originating from heart, kidneys, or liver?
The symptom onset would give a clue as to the etiology. As we had discussed previously, abdominal distension, which was preceded by decreased urine output and then followed by pedal edema, would point towards liver as an etiology, whereas pedal edema coming first and then abdominal distension coming later would point towards as congestive heart failure. And of course, it will have concurrent symptoms of orthopnea and paroxysmal nocturnal dyspnea. Whereas in renal failure, there will be more of facial puffiness and pedal edema associated with abdominal distension.
So very important points other than these two, which will point towards liver as etiology, which was there in this case, and something which will have pointed, which is not obvious in the history in this patient.
So if he reports a history of associated dilated abdominal veins, that would be point towards liver as etiology.
And what is there in this patient?
Decreased urine output.
And decreased urine output.
Decreased urine output preceding
the ascites.
The abdominal distension. I think that is a way. So those are the 2 pointers that liver is the root cause here. Fine, go ahead.
Siddharth, what is the connotation of ascites in patient with chronic kidney disease? Does it happen? Is it frequent?
Sir, it's not frequent, but it has been seen in patients who are on hemodialysis, which can be termed as nephrogenous ascites. And in such cases, we will have to intensify the dialysis regime.
No, in the absence of dialysis, when do you suspect that this could be CKD-related ascites? See, if you are already on dialysis, then you don't need to discuss about it. It has to be a part and parcel of that. So in this case, like you said, you asked about the history of renal disease. other issues. Mostly it will occur in patients who have a predominant hypoalbuminemia as a presentation, like nephrotic syndrome, or those in which there is a direct tubular involvement. If there is a parenchymal component of kidney disease, then ascites is usually not an important manifestation. Like in nephrotic syndrome, because of the gross hypoalbuminemia or amyloidosis, you are likely to have ascites. Otherwise, in a common garden variety of CKD, you will have other telltale evidences of renal disease rather than a
Dr. Arora, your audio is not very clear.
I'm joining from is it clear now?
No, not yet, sir.
What I'm saying is in a patient with in a patient with kidney disease, so if you have a frank hypoalbuminemia as a part and parcel of either amyloidosis or nephrotic syndrome, then you are likely to have ascites. But otherwise, in a common garden variety of CKD, because of say shrunken kidneys, ascites is usually not common. Go ahead, Siddharth.
Yes.
So for nutritional assessment, patient's body weight is 59.2 kg, corrected BMI is 21.2 kilogram per meter square, mid-upper arm circumference is 22.5 centimeters. There is no evidence of fat or water-soluble vitamin deficiency. There is no evidence of any micronutrient deficiency, and patient's performance status is ECOG 1.
What about the tricep skin fold thickness? TSF?
So no, sir, we did not assess the tricep skin fold.
Suppose you don't have the caliper. Which caliper do we use? Lange, generally Lange. And you just have to pull this part and then see that it comes within your thumb and the finger. And if the distance is more than about 15 millimeter, you are okay. So at least you can say that he has adequate fat. What does mid-arm muscle circumference or upper arm circumference denote?
So mid-arm muscle circumference is for fat-free lean mass, so it specifically points towards the muscle mass, and it can be calculated from mid-upper arm circumference. But for that we'll require tricep skin fold value.
Yes, so that is a very good sign. How do you do it? Can you raise your shoulder and then tell me how do you do mid-upper arm circumference? Show how do you do it?
So it's midway between the olecranon and the acromion process, and usually in the left arm.
And in a hanging situation, not in the raised situation. The arm is resting comfortably close to your chest. Okay, and then you can do it, or resting somewhere. So muscles are not in action.
Can you tell what is any other validated tools for nutritional assessment? Can you just enumerate?
So for bedside assessment, the dynamometer would assess the hand grip strength. And so then for advanced techniques, we have CT scan to measure the muscle area. There could be CT, bioimpedance analysis, DEXA, and MRI. MRI scan has not yet been validated.
What is subjective global assessment, SGA?
So subjective global assessment includes 5 parameters. Certain, actually, I don't know the details.
Okay, so you should read about subjective global assessment. It's validated in cirrhotics. There is a Toronto scale, which is also validated in the Western population. So you should know about, so you did talk about the CT sarcopenia and which is appropriate. And of course, the other tools which you mentioned. So that's okay. We can go ahead.
So moving on to per abdominal examination. On inspection, the abdomen appears distended with plank fullness. The umbilicus is inverted. Overlying skin appears shiny with striae, and dilated superficial veins are noted over the periumbilical region. There are no prominent back veins, no scars, sinuses, or visible pulsations, and hernial sites are normal. On deep palpation, the findings of inspection are confirmed. On superficial palpation, the overlying temperature, skin temperature is normal. There is no tenderness and the direction of blood flow noted in dilated veins is away from the umbilicus. On deep palpation, spleen is palpable 4 centimeters below the costal margin along the splenic axis. It's firm with rounded borders.
In no free fluid.
So on percussion, I have mentioned that there is shifting dullness, liver span of 10 centimeters. On auscultation, vowel sounds are normal, and there is no audible bruit or venous hum. And on genital examination, there is no evidence of testicular atrophy.
Okay. Continue.
On examination of other systems, respiratory and cardiovascular system is unremarkable. Central nervous system examination, patient is conscious, oriented to time, place, and person. No constructional apraxia was noted, and a patient has an MMSE score of 26. So,
before you go to diagnosis, I'll just take some of the questions regarding methodology of the examination. So one question is, how do you measure the liver span? That's asked by the audience.
So we begin with percussion on the mid-clavicular line, starting in the 4th intercostal space, percussing downwards till that a dull note is heard. So that is usually in the 5th intercostal space. And then we percuss downwards till below the costal margin. And in case of ascites, it is difficult to estimate the liver span. So the distance between the two is measured in centimeters.
So you measure you identify the point of the upper border of the liver, which is the first dull note when you're percussing in the mid-clavicular line. And the lower border you estimate either by palpation, where you can feel the lowermost edge, or if you cannot palpate, then the subcostal margin is what you can assume. And the distance between these 2 points is what gives you the liver span. The second question asked is about the direction of the veins. How do you interpret that? Because somebody has actually asked, shouldn't it be towards umbilicus? So why do you think in your patient is the blood flow away from umbilicus?
In portal hypertension, the blood flow, the dilated veins, they represent recanalized paraumbilical veins. So the blood flow is away from the umbilicus, draining from portal to systemic circulation. So the veins actually open into superior epigastric and inferior epigastric veins.
So in short, tell me, how does caput medusae form? And what is it?
So they are recanalized paraumbilical veins.
No. Which vein gets recanalized for you to see a caput medusae? Which umbilical vein?
Left umbilical vein.
Correct. So that gets recanalized, and that will open up the shunts between the, which all shunts will open up? From the umbilicus downwards, which will be the shunts, and from umbilicus upwards, what will be the draining veins?
From umbilicus upwards, we have inferior epigastric and superficial epigastric.
Yeah, but they will ultimately be draining into the subcostal veins, and below will eventually be draining into the tributaries of the femoral veins. That's how you'll see them dilated.
Inferior mammary above, the veins will drain into inferior mammary and go up. Okay, superficial epigastric, inferior mammary, and then they'll go up. All right. We have an HCC case, so we have to move forward. It's not a cirrhosis case, so please go ahead.
The final diagnosis for my patient is a decompensated liver cirrhosis with portal hypertension, with moderate splenomegaly, with ascites, without any clinical evidence of SBP, hepatic encephalopathy, GI bleed, or coagulopathy. In view of the history of low urine output, I would like to rule out associated AKI. And the etiology of liver disease, I would likely be hepatitis C related. One, second NASH, and third Hep B. And in view of my finding of moderate splenomegaly, I would like to keep portal venous thrombosis as cause 1 for decompensation, followed by HCC, followed by natural progression of the disease.
Is that the order of your priority? First is HCV. Ankita, why HCV?
So though the studies from India, they usually NASH-related cirrhosis is more prevalent than HCV. So, but as Akash spoke, there could be a changing epidemiology recently, and
you see, I thought this patient is diabetic. There is history of coronary artery disease. There is nothing to suggest HCV in the past. So why do we want to implicate HCVs ahead of, say, HBV and NASH?
So non-diabetic patient.
This patient also has history of coronary artery disease.
Even then, he has metabolic traits.
Yes, sir.
So first should still be NAFLD, not NASH. NASH is a definitive positive diagnosis. You can't write NASH. Should be NAFLD. Okay.
Yes.
And why do you put portal vein thrombosis? You think it would have been missed on ultrasonography if it was big enough? You see, the portal vein thrombosis, which will lead to decompensation, has to be involving the major vein. Yes. Isolated, standalone, one-sided portal vein thrombosis will not decompensate you. Do you think it would have been missed?
So it could have been missed by ultrasound.
Big thrombus could have been missed. If it was an HCC, what type of HCC will be missed on, say, ultrasonography?
So, less than 2 centimeters. So the sensitivity of ultrasound for less than 2 centimeter HCC is low. It's around 20%. So that could be missed.
That would decompensate 2 centimeter HCC?
Oh.
No, I disagree with the figure that you have given.
Ultrasound is very sensitive up to lesions beyond 5 millimeters. There is no question. And how will you see an ultrasound a 1 centimeter lesion? On ultrasound, 1 centimeter HCC. What is the echo pattern?
Is it hypo, iso, or hyperechoic?
Yes.
Hypoechoic.
Is it hypo or iso or hyper? Siddharth? Any other resident across? It is hypo. All tumors less than 1 centimeter are hypo. This is the beauty of ultrasound. And what is the doubling time of this tumor? From 1 centimeter to 2 centimeter. These
6
are
months.
Huh?
6 months.
Yes, you're absolutely on dot. 5.9 months. These are landmark papers of doubling time of less than 1 centimeter. Then it becomes iso, and then it might become hyper or remain iso or hyper. That is one thing. One more thing is, why do you think portal vein thrombosis as the first cause? How will a cirrhosis with PVT present?
So 30 to 40%, it will be incidental finding in 30 to 40% of the patients.
Very good. Then, in the remaining?
So in the remaining, it can present with decompensation in the form of ascites and variceal bleeding.
Yes, it can be, but a complete or an incomplete occlusion, PVT would definitely give ascites in a much faster time frame. And also, often it is a symptomatic thing. if there is an ascites present. Otherwise, it can be asymptomatic in a large number of patients.
Is there any finding on examination which has given you a hint whether it could be PVT?
So, 4 centimeter palpable spleen because of splenomegaly. So I kept PVT as the first cause of decompensation.
Is it not common in patient with cirrhosis to be having spleen, or do we always have to implicate portal vein thrombosis? I thought it was a part and parcel of a advanced liver disease, just a reflection of portal hypertension.
Yes, sir. So, but a 4 centimeter palpable spleen, like moderate splenomegaly. So,
It doesn't tell you it is PVT. No way.
So you will look for it, but it does not mean it is very common in patients with portal hypertension to have a 4 centimeter spleen.
What do you mean by natural progression and ascites?
So natural progression coming to ascites would be initial presentation. It would be with uncomplicated ascites in the form that it is not accompanied by any.
Why does it occur? Why?
Because of the pathophysiology, there is, as the splanchnic vasodilatation progresses and the cardiac output decreases, the ascites will progress from an initial diuretic responsive stage to becoming
Microthrombi, cirrhosis is a vascular. Complications of cirrhosis are vascular diseases. So development of microthrombi in multiple parts of the portal vein, radicals, branches, and the hepatic vein. That is the most important part. I think. Okay, let's move. We have only 60 minutes left. Go ahead.
Coming to investigations, I would like to have the hemogram.
We would like you to do 4 tests. This is my way of doing things. 4 tests are permitted to make a diagnosis. Which 4 tests will you do?
Sir, I would like to have hemoglobin, platelet count.
तो क्या diagnose करोगे hemoglobin से? Anemia कर लोगे. आपको 4 टेस्ट करने, आपने बताया कि एसाइटिस है और HCC का डायग्नोसिस हो सकता है. You are permitted 4 tests. That includes one of ultrasound. You are left with 3 choices. होता है KBC में 3 choices और है. 3 choice में diagnose करना और खर्चा भी नहीं करना.
Siddharth, you have to make a diagnosis, possibly come to conclusion, and possibly also decide the nature of therapy in these 3 tests. I think these tests should be sufficient. So what are those?
Specific tests, what will you do?
One would be ascitic fluid analysis.
For what?
Sir, to confirm that the ascites is secondary to portal hypertension and there is no associated SBP.
And no TB?
And yes, peritoneal possible.
Okay. Number 2.
Number 2 would be, sir, USG abdomen.
वो तो हो चुका. अब नंबर
HCC नहीं है, कुछ नहीं है ना?
नहीं HCC. अब क्या करोगे?
C2.
You can say Ankita loudly.
So CT, multi-phase CT abdomen.
Multi-phase CT. All right. So let's go to the multi-phase CT. Do we have multi-phase CT?
So
Yeah.
this is
It's okay. High sag ascites. We are on the diagnosis for HCC or not. RBCs. Okay. Now audience poll. All right.
Here is a poll question. In which of the following conditions serum ascites albumin gradient is unreliable?
हो गया चलो भाई. Can we move forward? Unless experts have another opinion.
No, I think everybody has answered correctly. Hypoproteinemia, I think overwhelmingly.
Quick, next. Of course, it can be unreliable in TB and others, but also it's okay. Yes, ultrasound में तो दिखा रहे हो lesion है. You are showing there is a lesion on ultrasound. Please read it.
So the liver span is 9.2 centimeter, coarse echo texture with surface nodularity. There is a hypoechoic lesion of 2 centimeters, which is seen in right lobe, appears suspicious. Spleen is 15.6 centimeters. Periportal, perisplenic collaterals are present. Portal vein is 11.9 millimeter, and moderate ascites is present.
Why are you showing us the report and not the picture? Where is the ultrasound picture? We are all used to reading reports like technicians. This is not permitted. If you cannot read an ultrasound, it's not acceptable. So why is this surface nodular? If it was an ultrasound, is it a micronodular or a macronodular? What type of cirrhosis? And that will determine a lot of things. You get my point? An
Yes, sir.
ultrasound is your first stethoscope of the abdomen. You have to see macro or micronodular. Right, number one. And also of the lesion, where it is located and what is the echo texture. Yes, Dr. Arora.
Yeah, Ankita, Dr. Sareen wants to know, does it have any meaning, whether it is micro or macronodular? Does it have different connotation in terms of etiology or the outcome? And what does it mean, macronodularity versus micro, pathologically?
Less than 10 mm size is micro, and more than that is macronodular. And the etiologies differ in terms of presentation. So, sir, like alcohol would have predominantly micronodular. Then NASH would also present with micronodular cirrhosis. Then
In terms of outcome and pathology, does it matter?
so in terms of outcome, I'm not aware if it makes any difference, but it is will.
In which one will you have a higher HVPG and portal pressure? Micro or macro?
Micronodular.
Why is it so?
Just
You are
think
right.
of it structurally, what happens?
So there'll be greater vascular remodeling associated with micronodular.
No. Is thinner nodule, thicker septa. Okay, nodule size is small, but between nodule the septa are thick. It's more fibrotic.
Given the choice, Ankita, you would like to have a macro or a micronodular cirrhosis? And what is the connotation? You see, macro versus micronodular will be the relationship between degeneration and regeneration. If regeneration is occurring at a brisk pace, that means you have enough of big nodules. That is a good sign. In micronodular, you do not have good regeneration. So given the choice, macronodular is better.
Okay, so your third test is now CT, multi-phase CT. Who is going to read it? Ankita, read it.
This is a cross-sectional image of multi-phase CT abdomen. It shows liver appears mildly shrunken with nodular surface, and there is a non-rim enhancing region which is seen in segment 8, which shows complete washout on the venous face with pseudocapsule formation. So likely suggests neoplastic etiology, and also there is splenomegaly and perihepatic fluid.
I can't see the portal vein very well, especially the right posterior. Was there any portal vein thrombus in this?
So
You don't have a good portal venous phase in this.
We need a venous. I don't think there's a venous phase photograph at all.
So there's no. Multi-phase CT report is there is a small ill-defined nodular subcapsular lesion in segment 8 measuring 2 into 2 into 2 centimeters, showing non-rim arterial phase and hyperenhancement and washout on venous phase and a pseudocapsule, and intrahepatic vascular structures are normal, mild to moderate free fluid with a spleen of 17 centimeter and impression of liver cirrhosis, portal hypertension, and segment 8 lesion could be neoplastic in etiology.
Can you go back to the previous?
CT film.
Yeah. So do you think this kind of a lesion in segment 8 without portal vein involvement has any relevance for your ascites?
Could this be responsible for decompensation?
Unlikely so.
So this is unlikely. Unless it involves a vessel, it will be unlikely. This is an incidental. Patients are going for liver transplant and you find a tumor inside. It's one of those. All right. So you must see. And what are you seeing in this spleen? Why is it so, different, perfused? What is it? Is there a lymphoma or something? So this is a flow phenomena, nothing else. Just to make you sure that it's a spleen, there are probably areas, I don't think there is a wedge, I don't think there is a splenic infarct, but this is probably a flow phenomena, but needs to be checked more carefully. Please continue. Fourth investigation. You need anything or you have won your battle in 3? You have an AFP which you showed. So that was your 4th test. AFP is 22, am I right?
Yes.
Now, so you think there is a confirmed diagnosis of HCC? Somebody asked a LIRAD score. What is the LIRAD in this?
It will be 5.
Yes.
Because there are all typical features. The size is 2 centimeters. It will be LIRAD 5.
So now you have a diagnosis of HCC?
Yes, sir.
But the AFP is only 22. What is the AFP above which you start worrying that it is HCC?
20.
So now it is revised to 5. It was 8 earlier. So a person who has a cirrhosis and has an AFP of 6, it raises a suspicion of HCC. It does not diagnose. There is a difference between suspecting HCC versus diagnosing HCC. For diagnosis, what should be the AFP?
So more than 200.
No. No other test is needed, only AFP in an adult, not a young. At what level?
So more than 1,000.
Yes, above 1,000. No other test is required, then it is HCC. And when you say it is diagnostic with the imaging,
When it is lesions with arterial phase hyperenhancement is mandatory, and more than 2 centimeters with showing venous washout or pseudocapsule.
any lesion plus 400 generally is considered, but it can be revised by different people. But above 1,000 generally is diagnostic.
Some people have a classical lesion with 200 also. So
yes, a classical lesion with 200 is also diagnostic. No more tests.
Ankita, what are the limitations of alpha-fetoprotein in diagnosis of HCC? Is it common to find it? Suppose it was normal with the same CT findings. How frequently is it raised? Say a 2 centimeter lesion in cirrhosis, what percentage will have elevated alpha-fetoprotein?
60.
60?
30 to 40%.
Yeah.
And 1,000 HCC would mean something else also. 1,000 HCC would mean it will not be amenable to most of the therapies, including liver transplantation. So that is, as Dr. Sareen said, a single most important parameter, that this is HCC, nothing else. There are exceptions. We have seen patient with hepatitis C untreated, you will have a very high HCC even without very high alpha fetoprotein even without HCC, who can be treated well. But in a patient with established cirrhosis and mass lesion, alpha fetoprotein of more than 1000 would preclude most of the curative therapies, including liver transplantation. But only 10 to 20% of the patient at this level will have raised alpha fetoprotein. So it has a very low sensitivity.
Okay, so just to continue and what Dr. Arora asked, there is a new June 21 upgrade on biomarkers for HCC. So AFP 35%, PIVKA2 close to 65%, and the two together above 90% sensitivity and specificity. So when you have to be sure, let's say your patient has 22, you can do a PIVKA. And if PIVKA2 is high, then you don't need to do anything. Suppose there was a lesion in the CT, no need. Then you don't need it. But if you have a doubt, let's say it's LIRAD 3 or 4, then you might use PIVKA2. Otherwise, don't spend money routinely. Okay.
One more question here I would ask is, supposingly you find a LIRADS 3, what are the chances that it will progress to LIRADS 4 or 5 in the next year?
40 to 50%.
No. So LIRADS 3 progressing to LIRADS 4 will be something like 20 to 30%, and almost 15% will progress to LIRADS 5. This got published actually this year only. So that's something which everybody should read about. Natural history of a LIRADS 3 lesion.
बड़े सवाल आ रहे हैं. Just one, somebody says AFP L3, lectin 3. So what is lectin 3, Siddharth? And how do you interpret it? Ankita? All right, so normally the ratio of alpha fetoprotein to its lectin variant called L3 is less than 15%. If it is more than 35%, it is diagnostic. Say you have an alpha fetoprotein of 20, of which more than 1/3 is L3. Then it is alone diagnostic. Then you don't need a PIVKA2. So AFP and its variant AFP L3, more than 35% is diagnostic for HCC. Very highly sensitive variant of this. All right, we need to move. यार लोग बड़े पढ़े हुए हैं आकाश, यहाँ तो सारे के सारे विद्वान हैं स्टूडेंट्स. चलो ये सब नहीं चाहिए हमें. हाँ. So now final.
So the final diagnosis is this patient is a 62-year-old gentleman with decompensated cirrhosis of liver, likely NASH related, with portal hypertension, with small esophageal varices, with ascites and hyponatremia, without SBP, GI bleed, hepatic encephalopathy, coagulopathy, or AKI, is child class B with a CDP score of 9, MELD score of 18. Is HCC, it's BCLC stage D, HKLC stage 2A, and performance status of ECOG 1.
All right, we hold on here. Suppose you are a good clinician and you don't have this hi-fi stuff. What is the Okuda stage? And I'm sure you are not aware of Okuda stage. It is the best bedside assessment of HCC. So let's say you have an ultrasound. More than 50% of the liver or less than 50% of the liver? Adha hai ya pura? First is amount or proportion of liver involved. All right, that gets a point. Presence of ascites, yes or no? Ascites plus gets 1 point. Bilirubin, more than 3, less than 3. More than 3, 1 point. Albumin, less than 3, more than 3. Less than 3, 1 point. Anybody who has an Okuda 3. So Okuda 3 out of 4, liver is more than 50%. ascites, albumin less than 3, bilirubin more than 3. Anybody who has 3 points, survival is 1.9 months. See, the first simple assessment and we will come to it in discussion before you go to all this, is Akuda staging, which I follow, and I think it's a very simple bedside tool of giving therapies. अब हम लोग कहते हैं कि साहब sorafenib above 3 नहीं देना है. This cannot be done. All this is very, very scientifically done by a very big series from Akuda, who has a big book on liver cancer. I recommend everyone to read Akuda's book on liver cancer. All right, let's come to what you have diagnosed.
Sir, I'll just ask one more score. What is the LB score? Very simple.
Yeah, very good. Please tell LB score. Very good.
So it's the
Albumin bilirubin score, sir.
Yeah. So
Very simple, very effective.
yeah. So log of bilirubin, a product of into albumin. So I think that's also very good for prognostication for HCC.
What is ECOG score, Ankita? Can you just tell us? And what is its implication?
So implication would be it will help us divide the patients into various stages and the therapy varies. The classification goes as ECOG 0 is the patient is able to perform premorbid activities, strenuous activities. In ECOG 1, the physical activities are limited. ECOG 2 patient is capable of taking self-care and more than 50% of the waking hours are ambulatory. ECOG 3 is more than 50% is in bed. For ECOG 4 is bedridden in 5 years.
I think a very important implication is anything more than 1, you will never have a curative therapy.
Yes.
So 0 and 1 is everything which is included up to child's BCLCC. Anything more than that, you will just have a palliative care. Very simple thing. I think it is extremely important to understand this.
This brings us to what are the most important 3 variables when you have a patient with HCC. One is ECOG or performance. What are the other 2?
Child class, the CTP score,
And the size of the tumor.
And the size or the behavior, tumor, patient, and the liver. Okay, continue.
uh,
2 centimeter lesion, what is the best option in decompensated cirrhosis? Liver transplantation, TACE followed by liver transplantation, TACE followed by lenvatinib, RFA, or surgical resection after control of the ascites.
All right. Majority say liver transplant.
There is I think, unanimity of opinion.
But several people have asked TACE followed by liver transplant. So the question is, can you do TACE in a patient with ascites?
no,
All right.
there will be clinical deterioration if the patient has a sign.
Second question is, do we need to do TACE? Suppose you treat ascites with diuretic and albumin, ascites dries up. So Dr. Sareen wants to know, do you need to do it before liver transplantation? And
It
when
can
and
be
how?
used as a bridge therapy if the wait list for transplant is
No, sir. In this patient, if we control the ascites, you can give him an option of a curative treatment like RFA or resection.
Do you think you can ever offer resection to this patient?
No,
not to this patient.
Why not?
because there is esophageal varices, which will it indicates there is clinically significant portal hypertension. So the risk of post resection, decompensation, and mortality is high.
And also, this patient has a bilirubin of 2 already. Resection is only up to A1, child's A1. When the bilirubin goes above 1.1, And of course, varices, you should not do resection.
In which setting of the patient do you need to do TACE prior to liver transplantation? Patient has option for both. He says, I can arrange money, I can have transplantation. So is there a time period during which the patient arranges the finances and the donor, especially in LDLT setting? So when do you do that?
If it is more than 3 months, the waiting period to prevent dropout.
Any other advantage of waiting?
When would you not want to do transplant immediately, even though there is a donor and the finances are arranged? That is what Dr. Arora is asking. That means you need to observe the natural behavior of the tumor. Is it extremely aggressive? When is it that borderline case where doing a transplant upfront will have a high risk of recurrence, or rather an unacceptable risk of recurrence after transplant?
In fact, one of the biggest advantage of waiting is, other than the fact in DDLT setting, you by default, by force, you have a waiting time. In LDLT setting, you have to arrange for finances and the donor. That gives you an excellent opportunity to a treating clinician to know the behavior of the tumor. In case the tumor is aggressive and the biology is bad, that this is the patient who's going to have increase in the size of the tumor, is likely to recur after liver transplantation. And that is where I think Dr. Sareen might correct me if I'm wrong, that there is an increasing role of doing liver biopsies. Now we are getting back, especially in New York, in Sloan Kettering, they are getting back to the liver biopsy to know the behavior of the tumor rather than banking upon radiology. Dr. Sareen would like to comment on that.
Yes, I would certainly, in fact, all our patients nearly get a liver biopsy now if it is safe and not contraindicated, for especially unresectable more often than the resectable ones. And the fear that there is a likelihood of seedling or going out is unlikely with the current therapy. So we favor liver biopsies in HCC. There are at least 10 or 20 variants of liver cancer, stem cell variant, Skirus variant. You know, there are so many variants. So therefore, we do biopsies very often. Coming back to the question, suppose there is no transplant available. I don't know if you have this question in future. So number one is not there. Then out of the 4, what will you choose?
So we'll optimize the patient, and then RFA would be the next best option.
Why RFA and why not TACE or why not microwave?
So RFA is, it'll offer, it is a curative treatment. TACE is not.
Both are curative. TACE is recommendation 1A. RFA is recommendation 2B. So in the EASL or the ASLD guidelines, TACE is 1. But yes, the problem is TACE will, kind of, compromise your hepatic artery. And therefore, if you want a transplant, sometimes there can be a challenge. Sometimes, not always. Second, you can handle 2 centimeter very well with RFA. And RFA done for 2 centimeter is like, what is the success of RFA therapy at 2 centimeter and 5-year survival?
5-year survival is more than 50%.
No, come on. Siddharth.
70%.
No, revise.
You're talking of RFA. Not
RFA, 5-year survival.
90% survival.
That is 1 year. 1 year survival, 92 to 95%. 5-year survival is around 60%. So with 2 centimeter lesion in a decompensated cirrhosis. 50 is less, 70 is a bit optimistic, but yes.
Is there a challenge in doing RFA in this patient?
Subdiaphragmatic location.
Yeah, so it's a very high tumor, and therefore RFA is technically challenging, not impossible, possible. We may have to create a pulmonary window, create a pleural effusion, or create a subdiaphragmatic ascites and then get it, but it is possible. But of course,
And
it's really challenging. So most anyone will be comfortable doing it. So such locations, what will be the next best choice? RFA, supposing you said RFA, the interventional radiologist says it is too technically challenging. I'm not comfortable for RFA. Then what else will you
Taste followed by liver.
taste?
yeah, and if there is if you look at the way RFA functions, and if you look at the physics of the damage caused to the tissue by RFA, the maximum diameter, the currently available probe is they are able to coagulate and cause extirpation of the tumor up to 2 centimeters. So up to 2 centimeters, it is a definitive therapy. Between 2 to 3 centimeters, you may have to ablate it with may have to cover it up with the TACE. Above 3 centimeters, RFA alone cannot be ever enough alone as a standalone therapy. Moreover, whenever there are vessels around it, whenever there is a vascular structure around it, then you have something called heat sink effect, and that is the reason MWA may be better off. There is no head-to-head comparison between RFA and MWA up to 2 centimeters. You can choose either of the two. This is cheaper of the two variants.
I see a comment by Dr. Sachin that if the decompensated survival is 50%, how will your patient live for 5 years? I concede and agree with you. Next. What is next? Yes.
So this chart is depicting HKLC staging system. So by this staging system, our patient falls into category 2A.
So what are you going to do in this?
So tell me, what is when you say HKLC or BCLC, why did we need a HKLC? What were the limitations of BCLC grading system?
BCLC was primarily done for the Western population. So there was for the Asian population where Hep B is more prevalent. So the progression and the natural course, so we needed a more specific system. And many of the patients, over half of the patients who fall into intermediate category in BCLC can be offered a radical cure in HKLC system.
No, can your patient fit into this BCLC? The patient has a bilirubin of more than 2. So this has preserved liver function.
No, sir.
So where will he go in this?
So he is at BCLC stage D.
So he'll be in stage D, but his performance status is, if I remember, 1. So how will he does not fit into? So majority, in fact, there are large series which will say 80% of the patients do not fall into BCLC scoring system. They fall outside. And that was the major need for getting HKLC, which is a shade better. But your patient does not fit into this. So what will you do for your patient now? Go to HKLC and then see where does your patient fall.
He falls into class stage 2A. So
he is child B. So this is much better for us to say, okay, child B is included and his performance is 1 and he is stage 2A. So your patient can fit into HKLC but not into BCLC system. All right. What are the other advantages what Dr. Shukla wanted to know? Advantages of HKLC. You can go for transplant in ECOG 2 to 4, child C, early tumor. This was never there in the, you can go for stage 5A liver transplant. My point, the intermediate stage, was the most difficult. How has the intermediate stage been permitted?
So,
Yes.
so has it extended the boundaries of resection? Let's start from there.
Yes, sir.
So, what way has HKLC extended the boundaries of resection?
Sir, patients with intermediate.
So patients with intermediate stage HCC by BCLC, up to 55% of them can be offered a curative treatment under HKLC stage.
No, that is fine. Let's go to the question. If you have a patient who has a intermediate stage tumor strictly from the size point of view, but also has invasion into a branch of the portal vein, let's say right branch of the portal vein, does HKLC permit resection in this patient? Have they
Yes.
any benefit?
So
If-
branch segmental, which is P1, P2 involvement patients can undergo resection, but that was not in BCLC.
2, 3, 4. Since you have started that, let us first restrict ourselves to HKLC. Then we'll go to the classification of tumor thrombosis. So, if you have a patient where you have sufficient FLR, future liver remnant, then just a presence of infiltration into the branch of portal vein is no longer an absolute contraindication. Okay, that is what HKLC tells us, and they've demonstrated a survival benefit in this group. The paper from Yao in 2014. Okay. Then second is you discussed about the intermediate stage. What proportion of patients who were BCLC B or C who were not offered a curative therapy based on BCLC will get a curative intent therapy on HKLC?
55%.
Okay, so this audience poll question. So sorry. So yeah, we can have vote from everybody.
Yogita, share the poll question, please.
Oh, so this is very interesting. So there's an equal split between option 1, 2, and 3. 25%, 40%, and 55%, almost equal. So Aditya, why don't you show the data? I think this I think is an important learning for everybody.
Yes. So in BCLC-B patients who are classified as HKLC2, the survival benefits of radical therapies compared to days was substantial, with 5-year survival probability of 52.1% versus 18.7%, which was significant. Also, in BCLC-C, patients who are classified as HKLC2, the survival benefit of radical therapies compared to systemic therapy was more pronounced, with 5-year survival probability of 48.6 versus 0%, and that is very significant. And also the HKLs, according to HKLC, we divide the BCLC-B cohort, then about 55.8% of the patients who are allotted for ACE can be offered curative therapy under HKLC system.
Okay, fantastic. Thank you, thank you. So coming back to our patient, supposingly this tumor was 4 by 4 centimeter in size and not 2 by 2 centimeter in size, and you had controlled ascites. What would be your preferred modality of therapy for this patient? Transplant is not possible. So transplant not possible. Tumor size 4 centimeter by 4 centimeter. Ascites now controlled.
ACE, sir. ACE would be our modality.
So in a 4 centimeter tumor, do you think TACE is of curative intent?
No, sir. We can downstage the tumor and then maybe.
TACE plus RFA is also an option.
Yeah, so tumors beyond 3 centimeter size up to 5 centimeter size, a combination of TACE and RFA actually has better survival than either of the two modalities alone. So again, if you are offering a curative intent, you have to offer a combination of TACE and RFA. So tell me the types of TACE that you are aware of.
There's a conventional TACE and DEB TACE, which is drug-eluting B.
Correct. So is there a difference between the two?
No, so,
In terms of efficacy or outcomes?
so studies up till now have shown that both of them are equally efficacious. And also there is no significant difference in the adverse events also. Though
Yeah.
it is said that conventional TACE has a higher chance of systemic toxicity, but that was not proven in the various RCTs which have been done up till now.
We are just discussing C-TACE and DEB-TACE.
Yeah, there may be some challenges, especially DEB-TACE. Earlier was thought that it is limited to a small tumor, and the larger tumors, DEB-TACE is not as effective, and it has lower complications and toxicities. So the lower complication and toxicities are still held. They are less compared to the conventional. However, whether DEB-TACE can reach to larger tumors is a questionable thing. So we do not generally do any conventional TACE, generally do DEB-TACE only. But my feeling is the toxicities are less and the drug delivery is longer for DEB-TACE. But any data Aditya has to update us on this? There was 2020 June, there was a very nice review last year where they still felt that DEB-TACE is superior. But if you have difference.
No, sir, I agree, sir. Actually, that
we agree.
we are now moving more towards that. I think most interventional radiologists are also more comfortable with that now.
Okay.
There's a question, Siddharth, from the audience. Siddharth or Ankit, any one of you can take. What is the management of, or what is post-embolization syndrome?
Post-embolization syndrome is a constellation of syndrome symptoms like ascites, fever, and tachycardia that takes place usually 48 to 72 hours after TACE.
And how do you manage that?
Sir, it will be symptomatic management. There will be no specific therapy that will be required.
Is there any therapy which has been tried in this group of patients?
I'm not aware, sir.
Okay, so people have tried corticosteroids, but again, it is not something that any embolization syndrome you will give steroids. So you have to be very careful in choosing the right candidate for post-embolization syndrome, use of steroids.
There is a hepatology randomized control trial which shows that steroids might be more useful than placebo. We generally give an acetylcysteine, but I'm not sure it works. We give it, but just for the heck of it. But can you predict post-TACE syndrome or post-TACE liver failure? And what is post-TACE liver failure?
Pre-selecting patients before TACE, BCLC categorization and HAP score. So, sir, patients who are...
Generally, people will do an ICG, indocyanine green, if it is available, to see the excretion or retention is checked, and ICG of more than 15 makes you worry. About 25 certainly worries us. But in ascites, ICG, or in a patient with jaundice, ICG cannot be done. Number two, if the albumin is less than 3, generally people will have a post-taste syndrome or liver failure. So try and see that the patient's albumin is above 3. Bilirubin generally should be less than 1.5 or preferably 1. But this patient had a bilirubin of 2, which is a challenge. So taste, you have very limited margin. Even indirect bilirubin being high is to be considered reliably that it is not a good sign. Third, if there is partial portal vein thrombus, even what Dr. Akash will discuss now, is also to be considered that you can have a post-taste liver failure. And the simple thing is if bilirubin rises to more than 2 times of the baseline or 1.5 in 24 hours, it is simply post-taste liver failure. But there are many other scoring system, but this is simple bedside. Please continue, Akash.
What will be your, how do you differentiate between tumoral portal vein thrombosis and bland portal vein thrombosis?
So this Avena criteria was given recently, in which AFP more than 1,000, venous expansion, arterial phase enhancement, and micro neovascularity, and area in contiguity with the tumor. So this predicts tumoral mobility.
Just change the order. You said all the features, but contiguity with the tumor, expansile thrombus, enhancement within the thrombus, any neovascularization, and of course, then supporting criteria is a AFP more than 1,000. So I think those are the features of for differentiation. I think very well put. Okay, now let's come back to this patient. In this patient, he has undergone a TACE, and there was no post-TACE decompensation. This patient has been listed for transplantation. When will you assess the efficacy of the TACE?
Sir, at 4 weeks, we will do a dynamic scan, either a CT or an MRI, to assess for the response to the treatment.
CT or MRI, and what will it depend upon?
So enhancing lesion.
So it will depend upon the viable lesion, which is the area of arterial phase enhancement that is seen.
No. So what our question is, one is, if you have used CT scan as the preferred modality for the staging before the procedure, then it is better to do the same modality to compare. But what is more important is if you have injected lipidol, then which modality will you use?
MRI.
Yeah, so if you have used lipidol, MRI will give you a better efficacy. 4 weeks or 6 weeks, again, depends on center to center, but most of the times it will be between 4 to 6 weeks. How do you assess the response? What are the response criteria?
So for loco-regional therapy, we would use the M-RECIST criteria. And for systemic therapy, we would use the RECIST 1.1. So according to the M-RECIST criteria for loco-regional therapy, complete response is absence of any enhancement, and a partial response is reduction in more than 30% in the sum of the diameters of the enhancing lesions, maximum diameters of enhancing lesions, viable lesions. And a progression is there is a more than 20% increase in the sum of the diameters of the viable lesion.
Stable diseases
and stable diseases in between complete response and progression.
Okay. Now, in the intermediate stage HCC, are there any newer concepts for management protocol in terms of systemic therapy and TACE? So
we can, intermediate stage, we can consider post-TACE, we can put the patient on any systemic therapy as a form of neoadjuvant.
There data to say that adjuvant chemotherapy following TACE is superior to only TACE?
Tactics trial. So TACE plus sorafenib, there is tactics trial which has shown that there is
Study has shown benefit, all other studies have been negative.
there is no use.
And therefore, routinely, you do not put your patients after TACE on systemic therapy. What is new is based on Kudos paper. What have you read that paper? Are you aware? What have they done?
No, sir.
Intermediate stage HCC, they have given lenvatinib upfront. Then they have repeated imaging after 8 weeks and then done super selective TACE for the residual viable tumor. So that is what is something new. It requires validation by other centers and therefore would be a different form of strategy, because here they are claiming that this could be of curative intent, which was not the case for intermediate stage HCC, at least in a proportion of patients. Okay, tell us about immunotherapy. What is immunotherapy? What is its current role? And then tell us about the limitations.
Then the drug classes are depending upon the molecules that are targeted. So we have CTLA4 inhibitors, which are ipilimumab and tremelimumab. Then PD-1 agonists, which is nivolumab, and PD-L1 competitors, which is durvalumab.
Where is nivolumab?
And nivo is PD-1 agonist, and pembrolizumab and nivolumab are PD-1 agonist.
Yeah, so what is the current role?
Are they first line or second line?
So second line.
Second line.
Which is the first line immune checkpoint inhibitors which are approved by FDA?
Atezolizumab.
Plus bevacizumab.
Yes, bevacizumab.
Bevacizumab.
Bevacizumab plus pembrolizumab, if I am right, but you can correct me.
Sir, Atizo bevaci.
Yes, you're right. Atizo and bevac, agreed. They are approved by. All right, so we have finished our time. Do we have more questions?
The question on TARE, I think we have not touched TARE.
Yes. So TARE generally, and it was Riyad Salem from Chicago who started this, and they put the radio sensitizers and the drugs through the artery, which goes maybe up to 3 centimeters. And earlier it was believed that if the tumor is very close to a vessel or there is portal vein thrombosis, TARE would have an advantage. And their time to progression and time to tumor free were higher in the TARE group, about 13 months compared to 9 months. And these are all both generally used for unresectable tumors. However, recent data in last 4 or 5 years have shown that TARE and TACE could be of equal value. Now, an alternative to TARE has come, which is SBRT, which we use regularly. We have done about 100 plus tumors of SBRT, radiation surgery. And if there is only portal vein thrombosis, no other tumor, first choice SBRT. If there is a large tumor with portal vein thrombosis, SBRT. And if there is an immune checkpoint to be given, inhibitor, SBRT followed by immune checkpoint. These are the new inventions or new approaches. But TARE, I think, being expensive and not so readily available is not as much. And there is no superior advantage to this. So what is the advantage of SBRT, if any one of you knows? Stereotactic radiation beam therapies. Okay, I'll give you some brief idea. So when you give radiation, Radiation causes injury to the tumor and also to the neighboring, slightly neighboring areas. So it causes release of several cytokines, including interferon alpha. So your CD8 cells, which were otherwise non-responsive, and your antigen processing cells, which were not responsive to pick up the tumor antigen, become responsive. Therefore, there is a huge advantage of giving radiation. Now, radiation plus immune checkpoint, why is it needed? When you give radiation, your T regulatory cells also increase. To inhibit T regulatory cells and the PD-1 inhibitor, so there is a gastro paper. So first you give radiation and followed by giving immune checkpoint inhibitors. This was an experimental study in animals, but now is generally followed. SBRT followed by immune checkpoint inhibitors is the way forward. And TARE is, of course, is a good modality, but not, it's very expensive and not readily available. I don't know about Bombay, which is a city of rich people. What do they do?
No, sir, I think it's difficult because most of 95% of the patients who need it cannot afford it.
Yeah.
I think it's practically very rare to do it here. I think there are no more questions. I'll just summarize, sir, and you can add if there's anything to the summary.
Yes, yes.
So we looked at when would we suspect HCC in a patient with cirrhosis. I think in every patient we should suspect who has come to us with a decompensation, and all patients with compensated cirrhosis.
Okay. Aditya, can you stop sharing slides so that we get a gallery view?
Yeah.
Akash, please carry on.
So the second thing is, in all patients with cirrhosis who are compensated, they should be under surveillance for HCC every 6 months. Here we use ultrasound and alpha fetoprotein. A word of advice here is, patients who are for surveillance, please request the sonologist to look at the liver in entire all the segments and not just do a cursory. Don't require the kidney and the pelvis report. Ask them to focus only on the liver. Those who are doing it themselves, I mean, you need to look at it in entirety. The second part is alpha fetoprotein is an important tool to suspect any AFP level which is abnormal. You should suspect anything more than 5. Conventionally, we were alerted if the AFP levels were more than 20, you would suspect that there could be HCC. A diagnostic level, remember that 2/3 of the tumors, hepatocellular carcinomas, will have a normal alpha fetoprotein. So a normal AFP level does not rule out an HCC. The modality for investigating an HCC would be a CT scan or an MRI, but the key thing is you need to have all the 4 phases. You need to have a delayed phase as well. And if you're using an MRI, then prefer to use a hepatobiliary specific contrast agent, because that will pick up additional 20% of HCCs as compared to a routine 4-phase MRI. Then biopsy is rarely needed for routine diagnostics, but like Dr. Sareen said and Dr. Arora put, there is an increasing role in prognostication in patients with HCC with regards to, and the use of liver biopsy. So that is something which is emerging now, but we still do not have definite endpoints for this subgroup. In treatment, the decision is based on the classifications that we have. We have the Okuda classification, which is a very simple tool which we have forgotten, but I think most of us should revisit because it is very simple, easy to implement, and you can apply it bedside. Amongst the recent ones, BCLC is the one which is most acceptable. It is useful for classifying the patients into different subgroups and understanding their natural history, but it does not give the treatment approach to a large majority of the patients. HKLC does a shade better. It increases the indications for liver resection. It puts more than half of the patients who would have been offered only a palliative therapy by BCLC in the intermediate stage into a more definite curative therapy with HKLC. With regards to the LB score is another one which is easy and which has got a prognostic implication. Treatment, whenever you can offer a curative treatment, please offer a curative treatment. For a less than 2 centimeter resection or RFA are curative, just like TACE also may be curative in this subgroup. Between 2 to 3 centimeters, both RFA and TACE are comparable. Between the size of 3 centimeters to 5 centimeters, a combination of TACE and RFA is superior to either of them alone as a standalone curative therapy. Whenever the patient is eligible for liver transplantation, patient should be offered liver transplantation. However, if there are features which are associated with a high risk of relapse after the transplantation, please wait for observing the natural history, give a cooling period of 3 to 6 months, and the patients will select themselves whether they can be transplanted or not. We also discussed the changing paradigm in the intermediate stage, which requires further validation, where systemic therapy followed by interventional radiology may be one of the options in the future. Just like you also have now the immune checkpoint inhibitors, which have come in big way. Atezolizumab is now the first line of therapy, approved first line of therapy, along with sorafenib and lenvatinib. And you have nivolumab and the second generation drugs like Durva, which are going to come very soon, which will become the preferred second line of therapies very soon. There's an increasing role of external beam radiation therapy, or the SBRT, because of its ability to stimulate the immune cells adjacent to the lesion. Also, the cost and the efficacy being comparable probably to TARE, although there are no head-to-head trials, and the ability of use of immune checkpoint inhibitors in combination with SBRT as one of the future preferred second-line therapies. So I think that is what I learned from today's seminar. Sir, you can add anything else. Dr. Sareen, sir.
Yes. Thank you, Akash. You have very comprehensively covered. I saw just one or two questions in the box and about whether PET-CT is useful. Not in general. PET has advantage, but yes, if you are taking for transplant, certainly PET is required to see if there is no extra hepatic spread. Also, when you feel that there is a high creatinine and you can't do, a simple non-contrast PET can also be helpful. But it is in the stage of evolution. You need a dual tracer PET, choline especially, to be able to say, yes, it is advantageous. Other than that, the portal vein thrombus and the role of PIVCA is very important. And we use in unresectable tumors a high dose vitamin K very regularly. There was first paper by Manoj in 2007 in American Journal, and the advantage of high dose vitamin K is immense. The word PIVCA comes from protein induced in vitamin K absence. So if there is high dose of vitamin K, the cell turnover decreases, the tumor progression rapidly decreases, and the advantage of giving high dose vitamin K is you have a bilirubin of 5, doesn't matter, portal vein thrombus with PIVCA of 70,000, and in 6 days you will find that PIVCA comes down. And 1 in 25% chance that the thrombus may even dissolve. 2 more studies were done but not published by 2 of our fellows. So in addition to the current scenario for inoperable jaundiced cirrhotic patient, you can use and try. I'm not saying it is the option. Is vitamin K. We give 50, 100, 150, 200, 250 and 300 milligrams in 6 days and repeat this high dose vitamin K for 3 or 4 cycles. It's like a chemotherapy. And this has been published by Omata that people who have a high AFP but no tumor, if you give high dose vitamin K, it can decrease the possibility of development of tumor. But do not believe me, try yourself. These are not in guidelines. The second important part is in a patient with HCC, try and see the radiological pattern, and the variants of HCC need to be studied. I think conventional treatment is now very standardized, and Dr. Shukla has very well said. And Govind, we want to thank you because we enjoyed this format and learned from my colleagues. And I can see that how good are the residents now, especially from Mumbai, I could interact. Very good. Congrats.
Thank you so very, very much, sir. I think this is one of the most wonderful master classes, starting from clinical case, in depth, what tests to do, how to interpret clinical findings. If we have a particular sign is present, then what does it mean? And going to depth of HCC. I think HCC is a very complicated subject, and for young residents, they discussed very, very well today. But before I thank you first, let me thank Siddharth and Ankita. They did wonderfully well today, and as you said, that all the residents and the kind of questions they posed were also remarkable. So this is a wonderful to see all the young residents participating in this masterclass, and we are thankful that we are able to hold this masterclass for our trainees and fellows. So thank you so very much, every resident, for participating in all the master classes. Dr. Sareen, Dr. Arora, and Dr. Akash. I mean, this couldn't have been a better panel on this topic, and your insight and clarity of thoughts which you discussed with residents, and I learned a lot. I'm sure the fellow colleagues as a participant must have learned a lot in this. Thank you so very, very much for enlightening on this topic. Aditya, thank you so very much. I think your questions were remarkable, and the way you conducted the session was also remarkable. Thank you so very much. So before we go to a couple of points I want to highlight. Number one, that all these classes, all the classes are put into ISC library, and also through YouTube, you can access these master classes. But I also like to remind you that we had a master class on HCC last year by Dr. Anil Arora. You may like to go to ISC library and go through the lecture by Dr. Arora to just refresh your knowledge about HCC, what we discussed today. So you can refresh more on that. Further, that one more announcement I need to make through this portal, that for ISGCon 2021, which is going to be held in Pune, so abstracts date has been extended till October 15. Till October 15. The Congress will happen in February, midweek, second week, and you can put your papers, plenary paper or paper for Young Investigator Award till that time. Certainly put as many abstract as possible this time. We will have a second master class. So second master class will be held on 3rd of October. Next Sunday, there are 4 centers in our country are doing India Live in endoscopy workshop. So we will not have master class on 26th of October. Therefore, you may join on India Live endoscopy workshop, and we'll have our next master class on 3rd of October. On 3rd of October, we will have a case on acute pancreatitis scenario, and this will be held from Asian Institute of Gastroenterology in Hyderabad. So we'd like to see you on 3rd of October. Till then, thank you so very much, everyone. Thank you, Akash, Dr. Sareen, Dr. Arora, Dr. Kale, Dr. Siddharth and Ankita, and all the participants. Thank you, Yogita, and thank you so very much, Dinesh. And have a great day. We see you on 3rd of October. Okay, bye-bye.
Thank you.
Thank you, sir. Thank you so much. Bye-bye.